Welcome to the Schar School Power Lunch. This week, it's a roundtable on healthcare policy. Infecting and killing millions. COVID-19 has tested the limits of science, medicine, and healthcare systems in every corner of the globe. Here in the United States, a debate over the future of the Affordable Care Act has been intensified with questions about the role of government in the provision of healthcare more broadly. How have healthcare politics changed? What is the new agenda? The Power Lunch welcomes Tom Daschle, former Senate Majority Leader and co-author of the book Critical: What We Can Do About the Healthcare Crisis. Zeke Emanuel, Leavitt Professor and Vice Provost at the University of Pennsylvania, Senior Fellow at the Center for American Progress, and formerly a Special Advisor for Health Policy to the White House Office of Management and Budget. And Sarah Kliff, an investigative reporter focusing on the American healthcare system for the New York Times. Welcome to the Schar School Power Lunch. I'm Justin Guest, an associate professor here at the Schar School of Policy and Government. It's great to have you with us. Zeke Emanuel cannot be with us today, unfortunately, but he has a good excuse. He has just been appointed to President-elect Joe Biden's COVID-19 task force. And so they have a pretty big job to do, and it's a challenge that all of us will be talking about here today. Fortunately, we have a more than capable and more than adequate replacement in Dr. Saskia Popescu, who is an epidemiologist and an assistant professor here at George Mason University, who actually co-authored a really well-circulated op-ed with Dr. Emanuel over the summer, all about whether and how to reopen schools. In fact, she's advising a variety of government institutions and organizations about disease prevention and as they all seek to resume work and day-to-day life. So it's really good to have you here, Dr. Popescu. We also welcome Sarah Kliff and, of course, Tom Daschle. What an honor it is to have such an expert group here with us today. Just yesterday, the U.S. recorded more than 145,000 new COVID-19 cases to set a new record high. In some areas of the country, the number of hospitalizations is already pushing hospital staff to the brink. Now, on Wednesday, another member of President-elect Biden's COVID-19 task force, Dr. Michael Osterholm, has advised or advocated a new 4 to 6 week shutdown of all work nationwide with government support for lost wages. Dr. Popescu, I think we should start things off talking about this idea, setting aside the politics for a moment, and of course there's a lot of politics to discuss, but setting that aside, medically, scientifically, is this a good idea? Is it worth the enormous amount of money that it would cost?
Well, we did see good success with it used in Germany. So it can be done, but it has to be done effectively. I think one of the biggest problems we saw with the US when we first did this is about 50%. And we really didn't use the time accordingly. So if we're going to go down into a closure or shutdown, a stay-at-home order, however you want to call it, I think the biggest task is to get everybody on board and to use that time effectively, but also really what we're starting to talk about more is instead of a widespread stay-at-home order, doing targeted intervention strategies first, really focusing on those high-risk activities and businesses like bars, casinos, indoor dining, and things like that, especially in areas of a high incidence and prevalence. You know, if you look at what New York is doing, they're using really zip codes, and I think that's been a great strategy. So I think people get very nervous when you talk about shutdowns. It's a very hard term, but if we look at what can be done, maybe more of an incremental stay-at-home order or a closure, that could be much more successful.
So if you were on the COVID task force yourself, that's what you would advise? What would you say would be the best first move?
Honestly, I think one of the challenges we face is this visceral response of wanting to do curfews. Curfews really don't work. And what is the goal of a curfew? So I think looking at the tried and true public health interventions that maybe we've been doing for a long time, but really aren't that effective for this virus, this particular outbreak we're experiencing in the US is important. So I would say, let's look at where we're actually seeing outbreaks occur and behaviors that we might need to adjust and account for. So really, that's why I mentioned bars, nightclubs, even, I say casinos because those are things that we really didn't talk about in the first few waves. And perhaps we really need to be addressing those high risk environments as we move into the holidays. So that's what I would really propose.
And do you think it's a matter of shutting those particular areas down or just more intense regulation?
I would say looking at areas that have high prevalence right now and doing that targeted intervention in the businesses we know are high risk. And, we're seeing a lot of honestly, healthcare overload and frustration in North and South Dakota, Minnesota, Iowa. And those are areas where we need to be giving public health and healthcare a break. And that means preventing new cases too. So I would really try to look at this from a regional perspective.
Great. Of course, COVID is inherently interacting politics with science. Senator Daschle, is a shutdown a good idea politically?
I don't think it is, as much as it might be the ideal solution. As Dr. Popescu noted, we had marginal success, or marginal is not quite the word I'd use. We had partial success last spring when we tried it, but we have a lot of political leaders in the country, governors, senators, members of Congress who are resistant to that. So you've got to balance the ideal with the practical, and I don't think the practical would accommodate it. Tony Fauci addressed this yesterday. Basically, he said, look, let's take some of the things that we know work, wearing masks, social distancing, doing the kinds of things, in addition to what Dr. Popescu noted about certain facilities around the country, and that may be the best approach. We just need broader participation for whatever it is we ultimately decide to do. We haven't gotten that yet. There have been great resistance among some states, including my original state of South Dakota, to many of these issues. So we have to get greater participation and more unified leadership as we address the challenges we know we're going to face in the next several months, especially.
What are some steps, Senator Daschle, that you think that Vice President Joe Biden, President-elect Joe Biden, can do to try to unify the leadership and to try to reconstruct American norms as it relates to the pandemic?
Well, that's a big job. And I think, first of all, I'd say there are things he can do as president that President Trump certainly did. He could undo some of the things that President Trump initiated by executive order. One thing that I think might be helpful is to initiate a new special enrollment period for the Affordable Care Act. That would accelerate the opportunities for people to get coverage and to get the kind of insurance necessary to deal with the challenges they may be facing. I think there are a lot of things he can do with the ACA to try to improve overall access and engagement. I think, secondly, working with Congress, of course, is critical. We need another COVID relief bill. We've got to get that because resources are just stretched to the maximum right now in all states. States and health facilities across the board need more resources for testing, for tracing. There's a lot of testing and tracing that still needs to be done. We have the vaccine coming on. We've got to make sure we have equitable distribution and efficient distribution. This could be very complicated given storage and transportation of at least some of the vaccines that we know. So there's just a myriad of things that we have to do around policy, around execution of the current plan that I think is currently unfolding, and then looking forward to the vaccine. So a lot on his plate, but it is going to take bipartisan cooperation in order to do it effectively.
Thanks so much, Senator Daschle. Sarah Kliff, you've written about a wave of hospital closures in rural areas and skyrocketing bills. We've now seen 3 successive waves of infection spikes of COVID-19, each larger than the last. What should the incoming administration expect in the coming months? And how should it be triaging all these challenges that the pandemic presents for healthcare provision?
Yeah, I think you have a health system that is used to getting by on how much volume it does, how much healthcare it provides. And because of the pandemic, you've just been seeing hugely decreased numbers of patients turning up at hospitals. And understandably so, it made sense when a lot of hospitals shut down their elective surgeries, shut down a lot of things earlier this year. And it's possible we might need to see some of those shutdowns this winter, both as hospitals need to increase their capacity to see coronavirus patients and as they're just trying to prevent the spread of disease in their communities. I think what's been especially challenging is that you have a set of hospitals, larger private hospitals that are probably going to weather this fine. They're going to lose a significant amount of money, but they had a big cushion coming into the pandemic. Then you have, like you mentioned, Justin, rural hospitals, safety net hospitals, which don't have that cushion and often, are dealing with 1 or 2 weeks of cash on hand. For them, these kind of declines in patient populations, these disruptions to their business models are a pretty big deal that could push them over the edge. I think the provider relief funds that were authorized earlier this spring were a pretty big and important deal. They kept providers afloat when they weren't getting that patient revenue. We haven't seen that additional round of stimulus. There's on and off talks about it here in Washington. We don't know when it's going to happen, but it seems like if we go through another wave, and you want to keep the healthcare system up and standing, you are probably going to have to do more of that provider relief work. You're also going to have to figure out who should it go to. Does it go to the hospitals who treated the most coronavirus patients, the ones that are closest to closing? Making those decisions are kind of the questions that, policymakers are going to have to deal with when they come in as part of the new Biden administration.
It's a lot to be taking on. Saskia Popescu, this year, many state governments buckled to the pressure to stay open. And of course, they experienced very severe outbreaks thereafter. With a new occupant in the White House and, of course, over 200,000 people dead now from the coronavirus, how should this equation change going forward in the face of future spikes? Is this sort of a do-over moment?
I hope so. I'm from Arizona, so this is especially painful and poignant for me because we did see a lot of politicization of public health in the state and a lot of overruling, if you will, what public health guidance was for unfortunate swaying and pleasing President Trump. And that was very hard. That really, truly did result in the significant surge we had in the summer. So my goal is that this is a time for a more national response. And instead of the siloing that we've been seeing, leadership to really rally all of the local and state leaders to get on the same page, have a defined set of goals and initiatives and response mechanisms. Because, if you have one state that is hypersensitive and conservative to public health, New Mexico is a great example of that. They've really taken this seriously and have leadership that is pro-public health and ingrained in that, versus Arizona. I think we've struggled with this. Our local leaders have been good examples, but if you can't get that support at a higher level, what do you really expect? And I'm hopeful that with the new administration coming in, it will be that moment to get everybody on the same page and reaffirm a national response through local leadership.
Justin, if I could just weigh in for a second, I think Dr. Popescu makes such an important point. You asked me earlier, what could President Biden do next year? And I think the word national is really one of the most important words in this whole effort. We've got to have a national strategy, a national plan. We can't afford 50 different plans that are in conflict with one another, where governors are vying with each other for supplies and so many other things. So I think it's so critical that we create a national strategy, implement that national strategy with as much coordination with all the states as possible. But I think that's an important aspect to how things must change next year.
Senator Daschle, in your interactions with governors and other state leaders, and I know they're a little bit more limited now than perhaps they were when you were actually leading the Senate, but do you get the sense that there's a craving for that? There's an appetite for this? Because it seems to be a lot easier on politicians and public officials when you have that federal leadership.
There is, but unfortunately, we've gotten into tribal politics these days in a very unfortunate and unhealthy way for our democratic republic. I'm very concerned about the tribal nature of politics. We have certain governors that are defiant, that feel strongly that they ought to be completely independent and make different decisions, call different shots than we would from a national perspective. So I hope that changes as things become more severe. They have to change, but we still have too much, I think, political gamemanship that works maybe for that particular politician, but it doesn't work for an effective national strategy to deal with this crisis as it continues to unfold.
You know, when COVID-19 reached the United States in early 2020, Senator Daschle, America, as you know, was already in the midst of a decade-long debate about the accessibility of affordable health care and the role of government in its provision. And it's, of course, something that you've written a lot about. And, you know, when Medicare was first offered, as you know, it was initially decreed as socialism, but it's now, of course, very widely popular in the United States. Republicans rode backlash to Obamacare to midterm victories in 2010, but Democrats defending Obamacare led to the 2018 blue wave. And then now, of course, in 2020, while Trump did not win the election at the presidential level, Republicans maintained very strong support down ballot, many cases because of a rebuke of socialism, so-called socialism. Senator Daschle, what do you think is going on here from a public opinion and a political behavior perspective? What does it mean for healthcare? This is all very confusing, right?
Well, I'm concerned for what it means for healthcare. I was hoping we could develop more of a national strategy. I think many of the innovative approaches to health that Joe Biden referred to, including a public option, are probably unlikely at this point, just because of the divided nature of Congress and as a result of its divided nature, its dysfunctional nature. We haven't been able to address even things as simple as surprise billing or drug prices, for which there's broad consensus today that we have to do something, but we still, and that hasn't just been partisan, that's been stakeholder versus stakeholder as well. So I'm hopeful, maybe not as optimistic as I'm hopeful that we can still find some common ground. I've generally called our current healthcare infrastructure a almost $4 trillion public-private partnership. And I think it's going to stay that way for a while. We don't have one system. We have a collage of subsystems, public and private, that really don't work all that well together. If you look at our quality statistics, our cost statistics, our access statistics, they're all in shambles today because we just don't have as an effective a system as we need. But I think President Biden is probably going to have to use his executive powers more than his legislative ones, at least initially. I hope I'm wrong. I hope there is an opportunity for consensus, but I'm not holding my breath.
What do you think he'll use those powers to do if you were going to look in the next year or two?
I would put it in maybe three categories. First and foremost, he can give the states great latitude to experiment and to do things to expand access, encourage as much as possible Medicaid expansion where it hasn't yet been expanded. So that's the first bucket. The second bucket is the ACA. There's a ton of things he can do on the ACA. One of the first things I do is junk plans. We still have too many short-term plans that don't work and are just a real disaster, and we got to get rid of them. But there's a lot of other things he can do using his executive authority, and I think that's important. And then the third thing is of course, probably most importantly, is addressing the immediate challenges we face with COVID and putting a national strategy together. That's going to involve the legislature, the Congress, for a COVID relief bill. It's going to involve engaging the states. And I really hope that we keep our eye on the international responsibilities we have as well. I worry a little bit about vaccine hoarding on the part of wealthy nations and the fact that not many poor nations are going to get vaccine for a while. It could be 24, 25 before they get the vaccines that they need. So we've got a lot of work to do, and there is a lot he can do with executive authority.
And we're going to touch on these topics of the vaccine and the Affordable Care Act momentarily, but I wanted to pick up on what you were mentioning about Medicaid. Sarah Kliff, you've written about how many states have sought to expand Medicaid coverage through ballot referenda. Voters in deep red Oklahoma approved expansion back in June. Why is Medicaid expansion something that can win with Republican constituencies when the politicians themselves are actually against it?
Yeah, I think it's notable what a strong record Medicaid expansion has at the ballot box. We've now seen 7 ballot initiatives to expand Medicaid. Most of them, by their nature, are in more conservative states that have declined to accept it on their own. 6 of those have passed, and this has brought coverage to nearly 1 million low-income Americans across the country. The first time it happened in Maine, people thought, maybe this is an anomaly, but now we've seen, like you said, Justin, it was repeated in Oklahoma, it was repeated in Missouri. I think what you see is once you separate Medicaid expansion and the actual policy of giving people coverage from Obamacare, it takes the politics out of it a little bit. And when you ask voters directly, should we take this federal money to give low-income people in our states health coverage, they are generally inclined to say yes. Whereas if you were to ask them, should we participate in Obamacare, they might say no. So it really, it shows this divide on where the Republican Party is. The Republican Party has been saying no to this when their voters are actually pretty enthusiastically saying yes. So I think it really tells us, and this kind of relates to the Affordable Care Act. When you offer people a benefit and when you offer coverage, it's typically quite popular. And once these things roll out, we have not seen a single Medicaid expansion rolled back. I would expect them to stay in place. The last thing I'd add is there's a question of how far this strategy can take you. Not all states have ballot initiative processes like this that can allow you to create Medicaid expansions this way. Florida is a really notable state that does. Organizers are looking at pursuing Medicaid expansion by ballot in Florida in the next few years, whereas Texas, which has the country's largest uninsured population, doesn't have this type of ballot process. So there you'd really need the leaders to step up and say that they want to participate.
And do you have any insight on that question that I asked Senator Daschle about how voters are viewing the subject matter?
Yeah, in terms of healthcare.
Yeah, exactly.
Yeah. I think it's really interesting. I think voter opinion on this is really fascinating, and some of it is driven by partisanship. There's a spot that Jimmy Kimmel, the late night host, did that I always think of, where he ran around New York asking people, what do you like better, the Affordable Care Act or Obamacare? And people had very strong opinions when actually these are the same law. But I think it actually really shows you the importance of the words we use and how things are described. And people were much more negative on Obamacare than they were on the Affordable Care Act. So I do think you see an openness to the Affordable Care Act developing. It's always been really divisive, but public polls do show it is more popular than it used to be, and it's slowly inching upwards. And I think the questions around public option and Medicare for all are also quite interesting. I had some really interesting conversations with voters that I think about a lot in Eastern Kentucky. I was there reporting on Obamacare enrollees who supported Trump. And I had a few people bring up to me, they didn't use the words Medicare for all, but I remember very distinctly one, Trump supporter hated Obamacare. She said to me, I just don't understand why we can't all have health insurance like what they do in Canada. She wasn't thinking of it as like a Democrat or Republican issue. It just seemed to make sense to her that the government should provide health insurance for everyone. So I do think there is some ideological openness to this, but because things are so polarized, when it gets labeled a Democrat policy, a Bernie Sanders policy, it kind of, really chops off the legs of anything like that having a shot in Congress.
Senator Daschle, in your 2008 book, you make frequent references to the power of interest groups, doctors, hospitals, insurance companies, drug companies that have a direct stake in healthcare policy preparation. But you also wrote that the problem is also rooted in the complexity of healthcare policy. Is it simply a communications failure? Why is Medicare so popular, but Medicare for all is so polarizing?
Well, I think it's exactly because of what Sarah has just outlined. I think there is power in words, and words conjure up sort of a framework, a prism through which we see many of these concepts. If we say Medicare for all, it automatically becomes a leftist idea. If we say insurance like Canada has or Europe has, it's more of a universal concept that people can identify with without some of that prism reflection. So I think that's a big part of it, but we can't underestimate first the role that stakeholder groups have, but then also the complexity. We have an enormously complex, and I would argue as a result, inefficient system that because of its complexity further complicates the challenges of trying to create ways with which to address cost, access, and quality more effectively than we have in the past.
Can I pick up on something, Justin, there? Because I think the surprise billing debate that Senator Daschle mentioned earlier is such a perfect example of how stuck things get. And he referenced this earlier. This is an issue that is very bipartisan. Republicans and Democrats, both those in Congress, the general public think we should end surprise billing, which is the practice of going to an in-network provider and ending up with some out-of-network bill from a doctor you didn't expect to see. And that's an area where you see such strong agreement that this is a problem we should get rid of. But Congress has been just absolutely stuck at figuring out what the solution is. And part of that has to do with these interest groups. Insurers and hospitals and doctors all have very strong, very different opinions about, well, who should pay those bills if the patients aren't paying them. And like Senator Daschle said, it's very complex. You have to come up with a new formula to decide, okay, what is the right way to pay these people if it's not going to be, bills going after patients. And that's really telling to me that Congress has been working for about 18 months now on solving a very specific, thing that everyone agrees is a problem. But because of the interests involved in it, because of the complex nature of healthcare, they just haven't gotten over the finish line. That doesn't make me optimistic for much other policy, something more controversial like public option or Medicare for all having much legs to go anywhere.
Yeah, that's a really important point. And let me just remind our audience that you feel free to ask questions to our panelists in the live chat box on your screen at any time. We'll be collecting those questions and asking them closer to the top of the hour. Let me turn our conversation now towards the vaccine. When a COVID-19 vaccine becomes available, Saskia Popescu, it will need to be distributed. What will happen when when the need for public health meets this sort of public-private health system that Senator Daschle just described? What do you think is going to be the best way to manage this?
Oof, that's a tough one. I think vaccine distribution, I should say, is not an easy topic. There's the ethical aspect of it. And one of the bigger challenges I think we face in the US that is very unique is vaccine hesitation. So, we can break down the distribution, the healthcare dynamics of it, but until we address the fact that 50% of the US population wouldn't take a vaccine, I think that's the biggest thing we really need to start addressing now. So I am very hopeful of a vaccine, but I also, don't want to put the cart before the horse. And I think right now, as we're in development, we should be focusing on renewing trust in science and healthcare and, frankly, our public health response to this. So that's a piece I honestly am worried that we're not having more conversations about, because as I work in healthcare and I see we were told early on in September to start preparing for a vaccine distribution plan before one had been developed, which was very worrisome. And healthcare workers, some of them were ready to sign up and get on the trials. And then the others I'm absolutely not taking that. And I won't work with someone who does. So I think addressing that mistrust in science and the science communication of it needs to happen first, if I'm being honest with you, because we've really eroded a lot of that we're seeing in the US and the lack of transparency from the current administration.
No doubt. And of course,
matters.
Maybe just the change of administration will do a lot more to actually reinstill that trust, because so much of it was driven by some of the politicized comments made by the Trump administration about rushing the vaccine in such that way. But, if you recall back in March, it was the rich and the famous who had early access to coronavirus testing kits in the most developed countries of the world. And our former panelist, Zeke Emanuel, actually wrote a piece earlier this year about vaccine nationalism and how we need to avoid it in the distribution of the vaccine when it comes out. And this is all about the ethics of what is the best way to deliver the vaccine, who deserves to get it first effectively when you have a limited supply. Do you have a thought about this, Saskia, about how you should distribute it and what the priority should be?
Well, I always defer to the much better bioethicist like Dr. Emanuel and Dr. Evans, but really what I think we all know is we need to focus on the frontline workers that are at higher risk for infection and exposure, healthcare workers, first responders, and then we start to really look at those most vulnerable and susceptible to severe disease. But I also think as we're having conversations about how to have sustainable COVID response, because that's the challenge we're in right now, is how do we sustain what we're doing without this burnout of all of our resources? And I don't just mean testing supplies or PPE, but also healthcare workers and the fatigue that we're all feeling living and working in a pandemic. So when we're looking at that sustainable approach, I think prioritizing teachers and educators is going to be key, because we do need to make sure that we get especially small children back into school. So I know that's something that is being discussed, but the challenge that we're also looking at is how to distribute this, especially if a vaccine is very temperamental and requires very specific storage. That makes things extremely difficult. So I would prioritize it that way. But again, there's much better multidisciplinary groups that involve many bioethicists discussing this.
Well, I think this is going to be discussed heavily once we get more information about this. Sarah Kliff, you spend a lot of time looking at random people's medical bills, as you all have already suggested. And you have reported about these surprise bills for COVID treatment, not just general medical bills, but specifically for coronavirus treatment, including massive fees that are often not covered by insurance plans. Can you tell us a little bit more about what's going on here, and what are the implications for access to the vaccine in the future?
Mm-hmm. Yeah, this is something I think about a lot because, as you mentioned, I do spend a lot of time reading random people's medical bills, which I'm not just seeking out willy-nilly, but they're bills the New York Times readers have sent us for a project I'm doing looking at the costs of coronavirus testing and treatment. And you see, I think what's relevant to the vaccine discussion are the testing bills that I read. Congress wrote laws, through the CARES Act that says that insurance companies are supposed to cover coronavirus testing completely, no cost sharing, no deductible. There should be no cost to the patient. What I am seeing a lot are, cases where sometimes those rules just aren't being followed. People are getting their normal $50 copay. Other cases where it's a little murkier, where there are extra services tacked on to the coronavirus test that the patient didn't know would be billed for. And sometimes these are things that generally regulations suggest they should be covering, such as the emergency room facility fee because you went to an ER for your test, or the doctor visit fee. Those are things that, again, insurance companies should be covering, are not always covering. And then you see, and those are instances where I think everyone's acting in good faith. They are trying to get paid for the services they're providing. They're billing for a doctor visit because there was a doctor visit, and it's a bit of a mix-up. You also see some, pretty clearly bad faith actors, people who come in for a drive-through coronavirus test, a story I wrote this week, and they're unknowingly tested for 20 other pathogens and billed $2,000 for the test they didn't even realize was happening. So when I think about vaccines, I do worry about these surprise fees coming up, and those surprise fees making people hesitant to seek the vaccine. I don't think it'll be the main thing going on. We've already talked about a lot of this is wrapped up in politics and how people perceive the vaccine, but I am concerned for vulnerable populations. They might be worried about, how much is this going to cost? Because we as Americans have become so accustomed to having to pay for our healthcare. And Americans, you look at any public opinion survey, a surprise medical bill is often at the top of Americans' worries when it comes to healthcare. So I do worry about, some of these fees I'm seeing get tacked on to coronavirus tests, getting tacked on to the vaccines next year when those start rolling out.
I did want to add something because, Sarah, your point really hits home. When pre-COVID, during COVID, but also post, is healthcare associated infections. This is an extremely challenging issue that we face globally, but definitely in the United States. There has been a mandate since 2008 where we're trying to force hospitals to do the right thing, right? By saying, okay, you have to pay for you have to get a penalty if you have so many healthcare associated infections, essentially saying we're not going to pay for bad work. And that really only impacts a very small percentage of Medicare payments. But I think the bigger concern is for so many of these coronavirus patients that are in intensive care units, they are more at risk for a healthcare associated infection. We did see spikes in CLABSIs, which are central line associated bloodstream infections, because these patients are so ill. They have a lot of issues going on, and that can increase the risk for it. So one thing that I really worry about is I think COVID highlights all of the issues we currently have in the US healthcare system with how we address quality of care and infection control measures. So if you come in and you have private insurance and you get a central line associated bloodstream infection because you've been in the ICU for 14, 15 days with COVID-19, your insurance has to pay for that central line associated bloodstream infection. And the biggest challenge we face is that there's really not good oversight. There's not good push to enhance these quality measures, to drive them home, and to make hospitals try and improve these measures outside of a 1 or 2% penalty. And that's on a very small group of patients. So I do worry that, this is highlighting the bigger issue of quality of care, and that we're really struggling to address it in the United States, because these patients are very sick, but HAIs, or healthcare associated infections, we love our acronyms in healthcare, I'm sorry. They've been around forever, and we're still struggling to face that. So if you have patients that come in and get hit with these massive hospital bills because of the quality of care, I think that speaks to a really big issue that we're still struggling to face.
One of my colleagues at the Schar School, Louise Shelley, has published work showing that fentanyl-related addiction and casualties are rising during the pandemic context. And I think that this is the tip of the iceberg for a number of sort of secondary illnesses and disease that's going on. Saskia, are you also seeing secondary disease and health matters also rising because of the pressures and also maybe avoidance of the healthcare system?
I think we've seen it more so in avoidance. I'm very concerned about cancer patients, oncology patients, especially people that are very early in the stages of diagnostics, that are a little bit more concerned about going to the doctors or the hospitals because they don't want to get COVID, or they're scared of, all they hear are hospitals being overwhelmed and stressed. I've seen a lot of patients that had undiagnosed cancer, and those very unusual symptoms, or just symptoms that they were writing off as something else, but not going to the hospital because they were scared to stress it even more. And I think that's a challenge for us in communicating what's going on to the public, that we still want them to seek care. But ultimately, we're going to see these excess deaths. We're going to see long-term health implications, and not just related to those that did have COVID-19.
Senator Daschle, you are a co-founder of the Bipartisan Policy Center. Now, bipartisan is not the first word that comes to mind when we're talking about this topic, obviously. Obamacare was a party line vote. The attempt to repeal it was nearly a party line vote. Why do you think partisanship and polarization is so high around this particular topic? I think we're having trouble with Senator Daschle's audio.
Sorry, I forgot to unmute. I thought somebody would do that for me. But I was just saying, I think it's a problem we've faced now for over a century. There is a consensus. If you're going to ask Republicans and Democrats, what is our goal? I think most would probably respond something along the lines of, well, we want to build a high performance, high value healthcare system with better access, better quality, and lower cost. I mean, that hardly anybody disagrees with that. I think the real issue then is, what is the role of government? And we've tried to work through that question. What is the role of government in creating this high performance, high value healthcare system now for a century? And it doesn't go away. And depending on political leadership on either side, it becomes more or less politicized. And it's been that way now for a long time, unfortunately. There have been exceptions. To a certain extent, when we created Part C in '97, that was fairly bipartisan. Part D was somewhat bipartisan. So there are aspects of healthcare. The CHIP program is a very bipartisan program. So there are exceptions, but by and large, it's still a question of what is the proper role of government. The ACA was the latest installment in the answer to that question, which was a little bit more government than we had before. We got 20 million more people that are insured, and just an enormous number of people who are benefiting from Medicaid expansion as a result. But the issue doesn't go away. It's around, we see it with drug pricing. What's the role of government? We see it with further access. What's the role of government? We've got a long way to go, and we inch along as we make progress. But that will continue to be the divide. What is the role of government?
Sarah Cliff, in your reporting in the field, do you gather any particular trends in where the demand is among the American public here?
Yeah, I mean, just to pick up on what Senator Daschle was saying, I think he's absolutely right that you have a divide over a really central question of, should the government provide health insurance to all Americans? And if you look at European nations or Canada, they tend to have consensus on that question. It's not even a question. It's like, well, of course, that's the role. And then if you look at, Gallup surveying on this, you see a real divide that kind of ebbs and flows, but we haven't really come to agreement on this. I think there is certainly consensus among patients that the costs are becoming unreasonably high. You hear a lot of frustration, and I hear this all the time in my reporting, with the medical bills that patients are facing. And a lot of that is getting worse because deductibles are rising. We've seen the size of an average deductible more than double over the past decade. That's the amount you have to pay before you get to use your health insurance benefits. I have talked to a number of Obamacare enrollees, even people who were supporters of the Affordable Care Act who, have a $6,000 deductible, and they're questioning, why am I even buying this health insurance policy when I don't have the money to pay for the deductible? I feel like this just does not work for me. It does not offer the financial protection that it is supposed to. So I think there is certainly an appetite from consumers. They want something done about this. But then, as Senator Daschle was saying, the question is, well, what do you do about it? And what is the role of government? And, it reminds me again of this surprise billing debate where there's been agreement, again, that this is a problem. But because there's so many private interests involved, because there's no consensus on what the solution is, it just gets stuck. But I do, it's hard to say, but I think we inch closer and closer to a tipping point where something will have to be done. Our healthcare costs keep growing faster than the rest of the economy. More and more of the burden of healthcare costs is shifted onto consumers themselves. There's only so much of our economy right now, about 1/5 of it is going to healthcare. There's only, so much that can get eaten up by the healthcare system before you have to get, some kind of intervention in place.
Saskia Popescu, the spread of misinformation, I think, about COVID has also been really worrying. And of course, that affects public opinion as well. Conspiracy theorists have burned down 5G towers because they thought that they caused COVID-19. People have speculated that it was an intentionally released bioweapon by the Chinese or other governments. You and your Schar School colleague, Professor Greg Koblenz, recently criticized the Trump administration's response in an article for the Bulletin of the Atomic Scientists as I believe it was Hear, See, and Speak No COVID. Why has it been so hard to distribute clear and authoritative information about the pandemic during the pandemic?
I think science communication isn't an easy thing. We all assume it can be done, but you have to have training on it. It's something we all struggle with daily. So I want to make sure that that's known. Nobody is inherently good at it. But when you're in the middle of a novel disease and a pandemic with especially one, a coronavirus that was originated out of China, and our experiences with SARS-CoV-1 and information sharing back in 2002 and 2003, I think there's already a lot of history there. But with an administration that is calling this the China virus or the Wuhan flu, a lot of terms that inherently link it back to China and don't just acknowledge the fact that that creates a lot of racism and unnecessary fear and misinformation. I think that kind of stems, that creates the issue, and it just stems from there. So part of the issue that we've really faced, I think, is you have an administration that has been inherently anti-science. And a pandemic of a novel disease is so complex, and it requires constantly having to take new information in, trust public health leaders, trust your agencies that you're utilizing, trust people like Dr. Fauci and the World Health Organization, and work together across not just the US, but also the world. And that's not something that this administration has been really good at. And then you have this situation that doesn't go away quickly. I think probably that's one of the biggest things that I noticed is I feel like the Trump administration felt that this was something that was just, they could throw some resources at for a few months and it would go away. That's not how infectious diseases work. And in fact, quite the opposite. So, I think once that happened, they just kind of washed their hands of it and stopped encouraging information and encouraging change and started to pivot to, well, there's this is bad information and we can't really trust Dr. Fauci and all of those things. And I think that just fueled it. So you already had this ripe situation where people had a lot of questions and stressful for the public to understand that guidance changes and science changes, but then adding an administration that genuinely lacks transparency and did little to encourage trust in science and public health, created this perfect storm of misinformation and disinformation, and why we probably need to invest more resources in infodemiology and understanding the nuances of that.
Can I just add, Justin?
Please, yes.
I agree with Dr. Pesky completely, but I would add 2 words: social media. Social media is just profoundly effective in creating a lot of the misinformation. President Trump has 142 million followers on his social media platforms, and truth now is just an option. And unfortunately, because truth is just an option, a lot of mistruth and a lot of mischaracterization of science occurs by the minute. Thousands and thousands of pieces of misinformation across the social media platforms every single day. And it's confusing. As we were saying earlier, healthcare is confusing, but it's especially so when people intentionally try to confuse the many people who are trying to understand and ascertain just what the real circumstances are. Social media has changed everything in the last quarter century, and we still haven't figured out a way to deal with that.
Sarah, from your perch at the New York Times, do you have any observations about this from the social media perspective that Senator Daschle just mentioned, and from the misinformation perspective that Saskia just described?
Mm-hmm. Yeah, I think it's a challenge that my colleagues and I run into every day, as you see a lot of polarization around where people get their media, who they trust for information. There's a lot of us at the Times who've been working very, very hard this year, particularly my science colleagues who are constantly reading through, all the latest studies, trying to make sense of it, all very dedicated reporters trying to get the best information they can out into the world. But then you also have a lot of this misinformation we've been talking about. And, we've been trying, to report on the misinformation to help our readers sort fact from fiction. But you are somewhat limited if a public does not see your news outlet as trustworthy or has reason to, question your news outlet. It can make it challenging. So it is a really big challenge. I think it's only gotten, I've been working as a journalist for 12 or so years now since I graduated from college, and it's become a really different environment just over the course of my career. When I started working as a journalist, Twitter didn't exist, social media didn't exist, Facebook was didn't have a news feed. It's just a totally different ecosystem where we're doing our reporting, and one that makes it a lot harder for facts to break through.
Absolutely. And I think we're all sometimes wondering if we're better or worse for it now. Let's just take this moment to remind our audience that next week we have a really fantastic panel that's going to be focusing on economic policy. If Americans are concerned about COVID, they are probably equally concerned about its economic impact. We'll be joined by the fantastic economics reporter from The Atlantic, Annie Lowrey, Steve Pearlstein, who's a professor, but also a wonderful columnist for the Washington Post, and Betsy Stevenson, former economic advisor for Barack Obama and now a professor at the University of Michigan. Don't forget to join us next Friday, the 20th of November at noon, right here on the Power Lunch. We'll take a 30-second break, and when we come back, we'll take questions from the audience, and I may have a few extra myself.
A world in motion. Our next generation of leaders needs new tools, sharper skills, leadership vision, and policy acumen to succeed in today's environment. A hands-on interdisciplinary education that offers a national and global perspective on the complexities of governance. The Schar School, a vision of excellence that melds theory with practice in the spirit of advancing the public good.
Welcome back to the Char School Power Lunch. Let's take our first question from the audience here. This is from Angela G. She writes, there has been a lot of recognition of a healthcare model like Canada's, but how much credence is given to a model more like Germany's? Would that type of system work well in the United States? I don't know who here is familiar with German healthcare.
I would be thrilled to take that question because I think it's a very interesting healthcare system. So just to provide some background, I think this is a fantastic question and one I think about a lot. So just to kind of provide a framework about the difference between Canada and Germany, in Canada, you have what's called a single payer system, which is a term a lot of people might be familiar with, where the government pays for health insurance for all citizens. The term single payer comes from the fact of one person paying for healthcare. In Germany, they have a multi-payer health system where you have all these, I believe they're called sickness funds in Germany, but you have hundreds of competing health insurers in a very tightly regulated market. What makes the German market very different from ours is the prices are regulated. So insurance companies compete on consumer service, on a little bit on network, on some extra benefits they might have, but the regulation happens in the competition happens in such a tightly regulated atmosphere that you don't see the extreme costs that you see in the American system. I personally think the German system might be a better fit for the United States just because of where we are. It would be a smaller leap to move all our private health insurers, Blue Cross, Anthem, into this tightly regulated system versus abolishing them completely and going to one single payer. There isn't, from what I understand, and I've done a decent amount of reporting on international health policy just because I find it really interesting as a menu of options for the US. There doesn't seem to be huge differences in terms of cost saving or efficiency between a system like Canada's or Germany's. The real key thing is regulating those healthcare prices. That's what's going to bring your prices down. That's what's going to make the system more efficient. And it could be that a system like Germany's actually is a slightly more similar to the American one. It's still a huge leap. That price regulation part is like a massive undertaking, and I don't want to suggest it's not. But I think this is a really smart question. I think Canada often dominates our health policy debate because they're next door to us, because Canada's system is the model for Bernie Sanders' Medicare for All system. But you have a lot of other systems across the world, like Germany's, that do offer a different model and possibly a model that would work better for the United States to achieve universal health coverage.
Senator Daschle, I was just wondering if in your conversations on Capitol Hill, this ever came up.
Oh, it does. I mean, there are constant efforts, and many good books have been written. In fact, Zeke Emanuel has just come out with a book over the last 6 months comparing different health systems. And so I would say a couple of things. Number one, Sarah couldn't be more on point when she refers to regulating prices. Our system, or our collage of subsystems, cost more because we pay more. That's really it. We rely more on technology too, but we pay more for almost everything, and that's why it costs more. And there has to be a more effective framework for us to be able to control prices that we do. And a big part of the reason is we have a fee-for-service system that rewards volume, and so we've got to figure out ways. And we've attempted now. This is another issue for which I think there's broad agreement. Fee-for-service drives volume. So how can we move away from that fee-for-service, more value-driven approach? And that's a big question too. But Germany does offer, I think, a good model for us. I'm not sure that any particular foreign model works precisely and could be adapted precisely. There's an interesting story. Taiwan, 30 years ago, went around the world and picked the best aspects of all systems and adopted them as their own. They now have one of the best systems in the world. But they took best practices and recreated a whole new health infrastructure using those best practices. I think we could take a lesson from that and do that too. But Germany certainly offers some good examples.
Would you expect that those power brokers, those interest groups that you describe in your book and that you now work with as clients, Senator Daschle, do you think that they would go along with this kind of system? Well,
everybody, as I said earlier, agrees that there is real a dire need for us to address the three main challenges we have. We have 100 million people who are either uninsured or underinsured. We have costs that exceed now $11,000, almost $12,000 per person. We don't rank in the top 20 when it comes to quality. Everyone recognizes we've got huge problems with our healthcare system, spending almost $4 trillion a year. So there is a recognition about the need to do it. But we come back to that central question: how do you fix it, and what is the role of government? And on that, we still have a ways to go, a long ways to go to reach consensus.
Thanks so much. I have an emailed question now. This is from Tim O'Shea, who says, the next frontier of healthcare seems to be the role of data. Google has just entered into a Project Nightingale, an agreement with Ascension Health Systems to allow Google to access health records for patients in 21 US states. On the one hand, data analysis might allow for better health outcomes, but there are also massive privacy issues. Where does the panel fall here? Do you have concerns? Who wants to take this one?
I can speak a little bit to that. So, I mean, I do think I think this question is certainly onto something that we are seeing these partnerships explored, and they certainly raise some ethical concerns about our patients being consulted about how their data is going to be used, what exactly is being shared with a third party. I think if this is done with patient consent and is anonymized, that's a different situation than if it's done without patient consent and, particular identifying details are being shared. One thing hospitals are having to contend with, we've seen a few stories about this lately, are these waves of cyber attacks. That data is very valuable to a lot of people who want to know more about patients. And so you really want to make sure that data is very buttoned up and secure. On the other hand, there could be a lot of value in this patient data and understanding what treatments are actually working and understanding what people are paying for treatments. There's a lot of data out there I would like to have as a journalist, but I think you do run into some of these ethical issues around what is the best way to provide that data, who should have that data. Again, this is a place where the US is a little bit different than other countries that have more nationalized healthcare system. In that case, in Britain, for example, the National Health Service would have a lot of this data. You wouldn't have to really think about who's sharing with who. It all went through one government entity. Because we have such a fragmented system, you don't have any government entity that's responsible for a lot of crucial healthcare data. And that's why you see these kind of deals in private industry filling a gap that might not even exist in other countries.
As an epidemiologist, Saskia, you guys rely on data so much, obviously, to do a good job. Where's the balance here from your perspective?
I should note I'm probably quite biased because I've never been in an electronic medical record system that I've liked. They're all extremely they're not robust. They're not designed with medical providers or anybody who's actually in the chart in mind. So I think there's a lot of room for miscommunication. The joke is that you can have one thing to document and there will be 6 places to put it. So everybody's documenting in different places. So data extraction and data usage and manipulation and being able to actually see what's going on is extremely challenging. From an infection control and epidemiological standpoint, hospitals have to have a single person just doing our data work because we pull from so many different locations to understand what's really going on in the hospital, what infections are occurring and at what rate. So I think the problem is, we have to kind of get down into the weeds a bit about, and really, as they start to bring in these larger companies to look at data sharing and usage within the EMR, I think the problem is we really have to go back to the drawing board and look at how electronic medical records and documentation in healthcare is done, because it is very fractured. It's not good. And I mean, again, I'm very biased because I have to do it all the time. And I think that it's inherently problematic. So for some systems that use meaningful use, like BioSense, which is syndromic surveillance, that's been really helpful about pulling data across multiple hospitals to get a bigger sense of it. But the hospitals don't see that as much, or else we don't proactively look at it. So I would be very, very encouraging of a new approach to data within healthcare. But really, to do that, I think we have to go back and clean out all of the mess that is the EMR system.
And just to speak to Saskia's point, I want to mention a story I reported earlier this year that looked at how fax machines were becoming an obstacle with coronavirus, where you had these, I think your point is very, very spot on, that this question maybe assumes that data is more advanced than healthcare than it is. You have all these systems that were built by private companies that don't talk to each other. And with coronavirus, you had labs and hospitals faxing their results to public health departments, because that's literally the only way they know how to talk to each other. I talked to a public health authority in Texas that one day their fax machine just started like vomiting paper all over the office because it was getting this wave of labs. And then someone has to pick up all the paper, enter it into the system. The data sharing, in some ways you think there's big data and there's Google and there's partnerships. There's also fax machines like spewing patient information on floors. There's still a lot that needs to be built out to actually make this a workable health data system.
Sarah, your point I love, because as somebody who sent those faxes, I mean, it's very antiquated. I think what I love when we talk about innovation in terms of building a better healthcare system is inspiring, but too often in healthcare, I think we don't take the time to really look at why it's not working and what's not working. Instead, we just want to move on to the next thing to make it seem to work better. So I think bringing Google in would be wonderful, but it doesn't fix the problem of documentation, of charting, and why we have the issues we do. So that to me has to be tackled before we start really bringing in these massive systems.
Senator Daschle, is there a public official's perspective here? The balance between, again, the scientists have their view on this, but politicians are always concerned about, where their citizens and constituents are thinking, and privacy concerns are real, and often people can be distracted by, horrible stories of breaches.
No, I think privacy is going to continue to be a very important policy and political issue. It's not going to go away. I think, and as we get into something we haven't really addressed yet, artificial intelligence and just the explosion of data derived practice and impact on healthcare, I think is another factor that will further complicate and maybe enhance our capacities. But along the way, privacy will continue to escalate as an important political and policy issue among policymakers of all stripes, Republican, Democratic, state, and federal.
This is definitely a space to watch. We're going to go ahead and conclude here. Thank you so much for joining us on today's Power Lunch. Thank you to my panelists from their perches in South Dakota, in Atlanta, and in Washington, D.C. Don't forget to join us next week on the Power Lunch, when we're going to be discussing economic policy with economist Betsy Stevenson, The Atlantic reporter Annie Lowrey, and of course, columnist Steve Pearlstein. Until then, thanks again for joining us, and have a very good weekend.